First of all, I would like to thank Professor Giakopoulos for the kind invitation to be today here. I will start, I will use two cases which will springboard this discussion. The first patient is a female, a Caucasian woman in her 30s with abrupt onset of full nephrotic syndrome, 2 grams proteinuria, serum albumin of 15 grams per liter, and 10 kilo increase in the body weight. The biopsy shows 21 glomeruli, 1 globally sclerotic, and 5 with FSGS, and the electron microscopy showed complete food processes effacement. Oops. The second one is a Caucasian male in the same age, but now with 6 gram proteinuria and no nephrotic syndrome, so normal total protein and serum albumin, no edema and increased blood pressure, 150 to 100. And his biopsies showed 8 glomeruli, with 2 with global sclerotic and 3 with FSGS, and electron microscopy showed partial food processes effacement. So, are these patients the same? How would you manage these patients? Would you give them the same treatment? First of all, we will start with what is FSGS. And what we know is that FSGS is a lesion. It's not it's a histopathological pattern of injury seen on a light microscopy. And it's not a specific disease entity. It can be a result of a wide array of pathogenic processes, and it cannot be diagnosed by pathologists. According to Columbia classification, we have 5 types. Now I have here only the 4. Collapsing, tip, cellular, perihilar, and not otherwise specified. However, this classification is based only on light microscopy and does not take into account how the degree of food process effacement on electron microscopy. Still, we don't know how these lesions raise, what is the pathophysiological process. And what we know is that the collapsing variant is associated with bad prognosis, that the tip variant is responsive to therapy and is associated with good prognosis, and that the perihilar variant is maybe associated with hyperfiltration and maladaptive FSGS. So how do we classify FSGS patients in our clinical practice? This is the CADO classification. You can see on one side we have primary FSGS, with patients with abrupt onset of nephrotic syndrome and diffuse food process effacement. Then we have secondary FSGS, which is totally with 3 completely distinct etiologies, viral and drug-induced, which is quite different from maladaptive, adaptive changes to glomerular infiltration. We have genetic FSGS, which can be familial, syndromic, or sporadic. And we still have some patients that cannot determine the etiology of the disease. So these patients have a clinical presentation similar to maladaptive FSGS, with proteinuria, increased proteinuria to very often to more than 3 grams, but they don't have nephrotic syndrome. And in the electron microscopy, they have segmental food process effacement. And a study in the United States found that more than 60% of patients categorized as maladaptive FSGS, they couldn't indeed find any etiology of the disease. So FSGS is a podocytopathy. The primary injury is the podocyte, and we know that podocytes are end-differentiating cells that they cannot regenerate, and that podocyte injury leads to podocyte loss, and this to denuded glomerular basement membrane, adhesion, activation of the parietal epithelial sacs, formation of FSGS, and FSGS means loss of kidney function. And podocytes respond to podocyte injury by the loss of intergitating food processes pattern. So in order to attach firmly, they broaden, and so in order not to detach. And the primary FSGS is presumed to be caused by a circulating permeability factor that is toxic to the podocyte and causes generalized podocyte dysfunction. There have been many candidates, with many of them being really good, but none of them have been proved to be the factor that it can explain most of the forms of FSGS. And what is very crucial to remember here is that in the primary permeability presumed FSGS, this form of FSGS affects all the podocytes. So we have diffuse podocyte effacement. Secondary FSGS is an umbrella term for FSGS caused by a diverse array of pathogenic events. Can be seen in any glomerular disease. In the biopsy of any patient with glomerular disease, we can see FSGS lesions. And that means that we have podocyte injury, we have glomerular injury. That means that we have kidney function loss, and we have to do something for that. Then we have the toxic secondary FSGS, which is drug-induced and viral-induced. We have a direct toxic injury to the podocyte, and these patients can also present with full nephrotic syndrome, and treatment is a treatment of the disease or stop of the medication. And then we have also the maladaptive FSGS, which is totally different. In the maladaptive FSGS, we have occurring condition in which we have hyperfiltration, glomerular capillary hypertension, and glomerular hypertrophy, and we have a higher demand. So it can be a result of increased hemodynamic stress or reduced renal mass, like also seen in small for gestation. It's shown in premature babies when they. And finally, we have also genetic FSGS, which may ensue from mutations in genes that encode podocyte proteins involved in slit diaphragm, actin regulation, nuclear pore complexes, adhesion proteins, and glomerular basement membrane. It's very common for the pediatricians in infants and young children. It's found in up to 60% of children with steroid-resistant nephrotic syndrome. And the clinical presentation here is also very variable. So most of the times they present with long-standing proteinuria, not in nephrotic range level, and very often they have also microhematuria, and very often they have also impaired kidney function. And, but we have also cases with nephrotic syndrome, but this is more common in children with steroid-resistant nephrotic syndrome. So should we consider, when should we go for genetic testing? When we have a mismatch between clinical presentation and electron microscopy findings, when it looks like maladaptive, but no cause can be identified, and where appears as primary, but fails to respond to therapy. So if we go back to our patients, the female patients with the abrupt onset of nephrotic syndrome, and we see what KDIGO suggests. So KDIGO suggests that if we have a patient with increased proteinuria, serum albumin, decreased serum albumin, so with nephrotic syndrome, serum albumin edema, and diffuse food process effacement, these patients, they have likely primary FSGS, and they should treat with immunosuppression. And first-line treatment is corticosteroids with the strongest existing data. And if the patient cannot tolerate corticosteroids, it's a high-risk patients for corticosteroids, like obese or diabetic patient, or with very bad osteoporosis. Then maybe we can also think calcineurin inhibitors. Goal of treatment, I can say the lower the better. We know from this study of 281 nephrotic FSGS patients that complete remission is associated with better survival, but we also know that partial remission is independently predictive of slope and survival from kidney failure. And how long should we wait until stop or discontinue steroids if we don't see a response? I think there's nothing more toxic than corticosteroids in terms of therapeutic options. So I think if we have a patient that doesn't respond to therapy, we have to stop early. And I think we have an answer from this nice analysis done in 70 patients considered to have primary FSGS. And the researchers found that the patients that they had more than 20% reduction in proteinuria, this was a strong predictor of response, partial or complete remission. But the patients that didn't have less than 20% reduction, they were less likely to respond. So it is suggested at 8 weeks to reevaluate the patient and see if you have a reduction, how much reduction in proteinuria do we have. And if the patient has less than 20%, maybe add additional immunosuppression, change the immunosuppression, or maybe consider genetic testing. So at this time, I would like also, what is on the horizon? Many studies, as in IgA, but not so many, and many with different targets. So intending to remove or inhibit the action of the putative permeability factor, to interfere with the innate or adaptive immunity to suppress the formation of the permeability factor, to correct hemodynamic stabilities, hemodynamic abnormalities, or to correct or ameliorate the injurious effects of genetic mutation. So we have to wait. And at this time, I would like also to introduce you and also a therapeutic approach that we want to propose. So because glucocorticoids are central in the therapy of nephrotic syndrome, and we know that they have also direct action on podocytes, we test in mice what happens if we inactivate the glucocorticoid receptor. And the glucocorticoid receptor is inactivated in PAX positive cells, so that means podocytes, PECs, and proximal tubular cells. And we use a model for food protein of proteinuria, reversible food process effacement, the protein overload model. And then we check the proteinuria in this model. And what we found, here you see the proteinuria, is that the GR inhibition, so the knockout mice, had less proteinuria. So this is something unexpected, as if you think we should accept an increase in the proteinuria. And then we also test this in wild-type mice, but now with treatment with mifepristone, which can inhibit pharmacologically the glucocorticoid receptor. And we had the same result. So we found that inhibition of the glucocorticoid receptor had the same effect as treatment with cortisone in reduction in the proteinuria. And we have the same finding in rats. When we use the pan-nephrosis model, the prototype animal model for FSGS, and again, proteinuria was reduced in the same extent with mifepristone and methylprednisolone treated rats. And we had also again, and then we moved to another species and another animal model, and we checked this also in zebrafish model, in which administration of metronidazole cause direct podocyte injury and edema. And again, treatment with dexamethasone and mifepristone had the same decrease in edema, like they had the same decrease. And then in Aachen, we also treat 3 patients with mifepristone. I will only show you one patient. It was a 42-year-old man with nephrotic syndrome, recently diagnosed with primary FSGS due to obesity and BMI of 38. Corticosteroid therapy was not considered, so we start with mifepristone, and already after 4 weeks, proteinuria reduced from 12 to 4 grams, and then we did add also cyclosporine, and in 1 month with dual therapy with cyclosporine and mifepristone, he had a full remission of the proteinuria. So I'll go back now to the female patient that we discussed before, to the male patient with proteinuria but not nephrotic syndrome. And according to the KDIGO, this falls in this category, so we have to evaluate for an underlying cause and exclude secondary forms of FSGS. And when taking a better medical history, we found that the patient had a low birth weight of 2.4 grams, and he also the last years followed a very bad life with high energy protein drinks. And so we decided that this patient has maladaptive FSGS, secondary FSGS, and he has to be treated with supportive therapy. And the treatment, the correct treatment to secondary maladaptive FSGS is to correct the hemodynamic abnormalities, to prevent podocytes from shear stress and prevent podocyte injury. No immunosuppression is indicated. And we have just to control blood pressure, to give RAS inhibitors, SLD2 inhibitors, and restrict sodium and protein. And why is this very important? Why supportive therapy is so central in all glomerulopathies, not only FSGS? I can also show you also with a very small experiment that we also have done. It is, we tried to see if it's possible to blow podocytes from the GBM. So what we did is we cannulated the aorta of flies and we perfused the kidneys with 50 millimeter mercury for 10 minutes, a stable pressure. And then we removed the left kidney, and we have the right kidney, and we perfused it for additional 5 minutes at 300 millimeter mercury or at supraphysiological pressure. And then we look, we count the podocytes. With a very specific method, we count the podocytes to see what happened. And here you can see in healthy mice the number of podocytes under the different pressures. And as you can see, you have so many podocytes with 50, as with 300, as with supraphysiological pressure. So amazingly, not even very high pressures can blow off the podocytes. And then we look at effaced podocytes. And in order to produce effacement of the podocytes, we administrate IDGBM serum in the mice. And we saw, first of all, that, okay, from the beginning, at the first study, we had a reduction of the podocyte number compared to control, and this can be explained because of the direct podocyte injury. But when we applied increased pressure, we had more podocyte loss. So effaced podocytes adhere to the GBM with less tightness, and they can be blown off more easily. So the translational message of our study is that acute podocyte injury with effacement renders podocytes susceptible to detachment and increased perfusion pressure. So this indicates for us how important is supportive therapy in glomerular disease. And this is now in the guidelines also of FSGS, not only IgA nephropathy. Before starting any treatment, also immunosuppression, we have to optimize the patient. We have first to give him supportive therapy. In the primary FSGS, it doesn't mean that we have to wait, as in IgAN, but first we have to give supportive therapy. Goal of therapy in maladaptive FSGS, there are no data because most of the studies with FSGS are with mixed population, which have both primary, secondary FSGS. We have some data from a big meta-analysis study in patients with CKD and not FSGS, which suggests that the reduction of 30 to 40% in proteinuria and preservation of eGFR seem appropriate surrogate markers. So we are not so aggressive. Because I think when we see a patient with 3 or 4 gram proteinuria, but who is not nephrotic, and he has stable kidney function, yeah, and we evaluate, we treat him, but we don't have this big headache that he is nephrotic, we have to treat him. And sometimes these patients are left untreated or undertreated. And I think that secondary FSGS is not so benign as we think, as we believe, and this is a finding that we will also find when looking in the patients with FSGS in the German CKD cohort. So we had 160 patients with biopsy-proven FSGS, and we tried to categorize, to classify the patients based on the criteria that I already told you. And we found that patients with secondary FSGS have a more severe GFR slope, lose more kidney function in the years compared to patients with primary FSGS. Sorry, primary FSGS is the red and blue, and green is, green is the secondary FSGS. It doesn't work. So secondary FSGS is not so benign as we believe, and I think, oops, this was not. And I think we should treat our patients, and the best what we can do is to recognize them and give them supported treatment, so lower blood pressure and give them lower blood pressure on the right medication. So to conclude, the identification of an FSGS lesion in a kidney biopsy of a patient with proteinuria does not establish a specific diagnosis. A correct differential diagnosis between the forms of FSGS requires a clinical pathological approach, and supportive treatment is the cornerstone treatment of all FSGS forms. Thank you very much.